So let's introduce the urinary system. And we kind of introduced it briefly in the lab, but we're going to introduce it more formally now. So we're going to start with like the functions, what it's doing. And this one is doing a lot more than a lot of times people give it credit for at first glance. Because obviously, you're peeing and it is getting rid of wastes, right? So it helps. It's one of the ways to actually fully excrete something out of your body. If you want to just have it out of your body, there's going to be nitrogenous wastes. Like the urea, that's the breakdown from, protein metabolism, as well as some muscle metabolism. It's going to have like creatinine. There's all sorts of ways. Anything that your body has that, metabolic waste from different processes. This is a way to get things out of your body. So that is happening. What other things is the urinary system critical for?
Water balance.
Yeah, a huge part is water balance. We've talked already with the renin-angiotensin mechanism. We've addressed this a bit. Your kidneys are either going to hold on to water or pee out larger volumes of dilute urine, depending on what your body needs to do to maintain its water balance, maintain kind of the osmotic balance of your blood as well. Like if your blood is starting to get really salty, you're going to be holding on to more water because you need to keep the water in your body. So water balance, both about blood pressure as well as about kind of osmotic balance of your blood and all that. We'll talk about that in more detail. What other kinds of things does it do?
You mentioned it was really important in maintaining blood pressure.
Yeah, so I'd say that would be a corollary of water balance. By corollary here, long-term blood pressure is going to be determined by water balance. There's some other something I mentioned during the urinalysis lab, another thing that it helps balance.
pH balance?
Yeah, pH balance. It's your long-term control for pH homeostasis. Again, because you can get protons out of your body. If you're too acidic, you can, all of these other things we've been talking about for pH balance, like buffer systems and changing pulmonary ventilation and all that, that is kind of a temporary fix. But for kind of long-term pH balance, you actually got to get rid of the excess H pluses or bicarbonates in order to reset the pH to its kind of base setting. So pH balance is going to be a really important role of the urinary system. But wait, there's more.
Like ion balance as well?
Yeah, totally. Electrolyte balance.
That's the word I was looking for.
But I mean, those are the ions. Rick, we've been talking about how all of these cellular signaling in the neurons, in the muscles, is so dependent on the concentrations of potassium ions and sodium ions and chloride ions and things like that. So it's critical that you have those. If you have too much salt in your body, you got to pee some of it out. If you don't have enough salt, you got to hold it in. So the kidneys are going to be totally checking out your electrolyte levels and adjusting appropriately. Right. We're going to see this. We're going to do a virtual lab next week. We're going to talk about it later on today during lab time. You're going to do a pre-lab for it over the weekend. But in this lab, we're going to have people drink more or less water. Some of the subjects drink huge amounts of water. Some drink little amounts of water. Some are eating salt tablets. Some are not eating salt tablets. And then you look at the composition of their urine over the next couple of hours. And, just as we can address this now since we're going to be talking about it. What would be your hypothesis for kind of the composition of the urine if somebody is drinking a lot of water? What do you think the effect that's gonna have on their urine production?
We're gonna produce more and it's gonna be clear.
They're gonna have large volumes and probably very dilute urine because they're trying to get rid of all that extra water to maintain their water balance. Whereas if they aren't drinking much water, they're gonna have much less volume because they're trying to conserve water. Same thing if you're eating a bunch of salt tablets versus not, how is that going to be reflected in the composition of your urine?
Darker urine?
Not so much dark. The color is something else. Although, I mean, it can be darker if you just have more concentrated urine, less volume, so that can be related, but think more just in terms of the actual ions.
Not the gravity thing, right? The special or the specific.
It's going to be related to that. There's going to be more salts in the urine. If you're eating a lot of salts, you're going to have to pee out more in order to maintain your homeostasis. Right? And that is going to be reflected in that specific gravity. The more stuff dissolved in your urine, the higher the specific gravity, the higher the density. So we actually are going to be looking at both specific gravity and sodium chloride concentration. And both of those we would expect to be higher if the body is trying to get rid of more of these salts, if you've taken in more. So just kind of making you think about the urinary system more than just a way of getting rid of waste. It's a huge part of what it's doing is actually doing water homeostasis, pH homeostasis, electrolyte homeostasis. So just kind of putting that out there. Other things that we saw, actually related to long-term blood pressure and water balance, we also saw that it released renin. So that's another actually way your kidneys are major players in dealing with your blood pressure control. They also do some other things. Your kidneys are actually the things that release erythropoietin, which I mentioned briefly. So renin was for blood pressure. Erythropoietin, do anybody remember what that was for?
Red blood cell formation?
This increases red blood cell formation. So if your tissues are realizing they're not getting enough oxygen, you need to increase the carrying capacity of your blood to move oxygen around. Your kidneys actually release erythropoietin, which talks to the bone marrow, increases red blood cell production. So you have more hemoglobin floating around in order to pick up the oxygen to deliver it places. Right? This is going to be released if you just go up to Tahoe skiing over the break and the partial pressure of oxygen is lower and your body is going to up its red blood cell production to become more efficient at carrying the oxygen around because there's less of a driving force to move the oxygen from the alveoli into the blood. Actually, they're important for vitamin D. The precursors for vitamin D are made in the dermis of your skin. That's how it gets the word D. But it's kind of activated by the kidneys. So the kidneys are actually playing an important role in making vitamin D. This we're not going to talk about so much, but this is necessary to absorb calcium. So if you don't have enough vitamin D, you don't absorb calcium as well. Right now, when it's pretty rare, because you drink your milk and it's got fortified with vitamins A and D. What happened to kids who, particularly the vitamin D gets, where the precursor gets formed in the dermis of your skin, and it needs sunlight for that to happen. So if you have kids who aren't getting enough sunlight and aren't making enough vitamin D and aren't absorbing calcium, what's going to happen?
Rickets.
Rickets. Rickets. Their bones are soft because they don't have enough calcium to make them hard. If you remember from anatomy, the bone matrix is a combination of the osteoid, like the collagen and the mineral salts. So if you don't have enough of the mineral salts, the bones are soft, and you get the little kids that are like bow-legged. Rickets makes your bones soft, and then they bow under the weight of your body. If you don't know the etymology of this always, the first time I heard this, it was kind of crazy. So what is orthopedics? What does an orthopedic surgeon do?
Isn't it like a bone doctor?
Yeah, it's basically works on bones and joints and stuff. But if you look at the etymology, ortho means straight, peds are kids. So a lot of what they would do, in the origin of this field, they would like kind of break the bones and reset them to straighten out the legs and stuff of these little kids who ended up bow-legged from rickets. So yeah, it's kind of a cool kind of history of why that word makes sense for that kind of doc. If you've ever seen them, it's carpentry. It's kind of crazy. It's like hammers and saws and stuff. It's kind of crazy. All right, but back. So these are kind of more things aside, but just for completeness, I'm throwing those in for the urinary system because the kidneys are involved with these as well. But we are going to focus on these things. And we will start with some basic anatomy, and then we'll get kind of focused down into the smaller processes going down in the little tubules and nephrons in the kidneys. All right. Let's see, let's try to do this well. So this is going to be kind of the abdominopelvic cavity. We have the descending aorta going down. We have our renal arteries going into our kidneys. The kidneys are kind of in your lower back lumbar region. So they're kind of near the back of your lumbar and the lower back region. Again, like the size of a bar of soap or whatever they say. And they are being fed by these renal arteries. And I don't know if people remember from the cardiovascular section, I talked about the percent of your cardiac output that actually gets delivered to the kidneys.
24%.
Yeah, it's 20 to 25% of your cardiac output is going into your kidneys. This is going to be important as we continue this discussion. So 20 to 25% of cardiac output is going. So that, how many liters per minute is that? What's resting cardiac output for somebody?
Wasn't it around 5 liters?
Around 5 liters per minute. So that means these kidneys are getting somewhere between 1 to 1.25 liters per minute of blood coming in. And so that obviously that's way more than they need to just kind of get their oxygen and nutrients. You got this huge amount of blood flow going into the kidneys, so you can do all that processing, all that electrolyte and water and pH balance going on that we've been talking about. So we're going to follow, kind of follow this as we continue on with our discussion of how the kidneys work. As the kidneys are doing their thing, the stuff that's ultimately going to leave the body, be excreted, as the urine, is going to be sent out through these little tubes called ureters. So let's add the ureters in our picture here now. Maybe draw that better. So these are conveying urine. So as the kidneys do their stuff, the blood comes, there's going to be renal veins as well that take blood back into the vena cava. So they have blood coming in and out, but then the stuff that they are going to now excrete from the body as the excess water and wastes and whatever is going to be urine. Urine is delivered via ureters. And fortunately for us, we have a little storage container called the urinary bladder that can store the urine until we're ready to, can actually get rid of it. The urinary bladder is basically a big muscular pouch that can store urine. It can store up to a liter. And then obviously you need another tube to actually get the urine out of your body, and that's going to be the ureter. I'm sorry, I'm spazzing on you, the urethra. So the urethra is what actually conveys the urine from the bladder to outside of your body. This is obvious, it's more of a female picture. The urethra is short, like about 1.5 inches or so, goes to the urethral opening in the vulva. In the guy, it's going to be going along the length of the penis. And we'll also have a lot of other things involved in there because you have to mix in the stuff for the semen for the reproductive functioning. But we'll do that later on. We'll talk about when we get to the reproductive system. Other things to talk about here. Control of urination. There are 2 sphincter muscles that are important for controlling passage of urine through the urethra. So there's going to be an internal sphincter, which is smooth muscle. And there's going to be an external sphincter, which is kind of the muscles of the pelvic floor, which is skeletal muscle. And the control of urinating or peeing is going to be another one of these spinal reflexes. Basically, there are going to be stretch receptors in the walls of the urinary bladder. So the urinary bladder can fill to maybe a couple of 100 mils without really stretching out much. But beyond that, it'll start stretching as it fills with more urine. And as it stretches, it sends a message to the spinal cord. And then there's a response. Remember, a reflex arc. We have the stimulus is stretch of the urinary bladder. The response is relax the internal sphincter. So when the internal sphincter relaxes, you're going to feel pressure on the next level down. And that's going to be that urge to pee. It's like, oh, I got to pee. Luckily, the external sphincter is skeletal. It's voluntary. So you can now decide whether it's appropriate time and place to relax the external voluntary sphincter and actually let the flow begin. If you keep holding it, the kind of urge goes away for a little bit, but then the reflex kind of reiterates and reminds you like, oh yeah, no, there's still pressure here and we gotta pee. So we're gonna see a very similar kind of situation with the digestive system. The rectum is gonna be filling up with feces, and there's gonna be an internal and external anal sphincter, right? And as the rectum gets full of feces, there'll be a spinal reflex that relaxes the internal sphincter, and you'll have the urge to poop, urge to defecate. And again, luckily you have a voluntary skeletal muscle, external anal sphincter, that you can then relax as appropriate to, to poop. So sphincters. The other things we can talk about here. The kidneys are held in place by a variety of different kinds of connective tissue, including this big, what's called an adipose capsule. Which helps protect them. Like if you've done been in anatomy, when you open up somebody and you're looking for their kidney, first you have to go behind the peritoneum, the retroperitoneal. And then even then you don't really see them because they're inside a big pillow of fat. You have to kind of slice open this pillow of fat to find the kidneys. The reason why this is worth talking about in a physiology class is one of the problems of people who like lose a lot of weight, like people who are anorexic or something, one of the things that can happen is you can actually have the kidney kind of droop, kind of fall down, because it's no longer supported by its little adipose capsule, and that can kink up the ureter, impair the flow. The word for drooping is worth knowing is ptosis. So you can have ptosis of your kidney if the kidney droops, kind of falls down. You can have if your eye, something happens to the muscles or nerves controlling your eye and your eyelid droops, that's also called ptosis. Ptosis is just as drooping. Other things we can talk about while we're still in the big picture is if you have different salts or uric acid or different things that actually precipitate out in the urine. Normally, urine is fluid, so it flows, kind of gathers in what we call the renal pelvis, goes down the ureters into here and then leaves. But if you have different things precipitate in the urine, basically think about like a oversaturated sugar solution turns into rock candy, right? Like the idea of crystals forming in a solution of very concentrated solute. If that happens, you can get what are called renal calculi. Renal calculi. What's another word for renal calculi?
Kidney stones?
Kidney stones. And again, they can be made out of a variety of different things. Depends on your diet, on your genetics. You're going to be more or less likely to get them. If you do get them, they can be really problematic because they're going to block the flow of the urine through the system. They're supposed to be excruciating to pass, to actually kind of get out through the system.
My husband had one a couple months ago. It was, not pleasant.
No, I have heard that it's incredibly painful.
When I was pregnant with my daughter, they thought I had kidney stones, but it was actually my main artery was smashing they were smashing my ureter with my uterus. And they had to put a stent in because it was like constantly as if I had a kidney stone. And I swear to God, it was more painful than actually giving birth.
Oh, yeah. So luckily now, if you have real kidney stones, they have ways to get rid of them without actually cutting you open. They have this, it's called like shockwave lithotripsy. I can put that name up here. Litho is stone. They basically like put you in this kind of bathtubby thing, and they focus sound waves on your on the place where the kidney stones are, and it shatters them, and then it makes them small enough so then you can pee out the sand afterwards. So that's kind of cool. Hold on, I'm gonna wait 1 second here. Ta-da. Yeah, I can just to I think, but that's not what I meant to do. Hold on 1 sec. Sorry about this. Here it is. Yeah, so kind of just going off, we'll talk about this a little more later, but I think it is just to give you a sense of what Nicole was talking about. It's worth actually looking at this. I'm going to share just to give you a sense of what's happening during pregnancy. On the right, this is kind of how all of your organs are normally. This is showing kind of full term when the uterus is totally swollen with the baby inside. You can see why a pregnant woman is going to feel like she needs to pee all the time, because here's the poor bladder totally squished down here, and why they tend to get indigestion, because here's all the intestines, so it's like there's, your organs are definitely compressed and having a tricky time in there as the little fetus is getting near term. So it's not shocking that I haven't heard about the kidney issues, but that's not shocking to me at all. So
I have a question. Like a lot of women after giving birth have like bladder control problems. Is it just that they're losing like control over that external sphincter, or is there something else going on?
exactly. No, it's so there can be damage to the pelvic floor during birth, and that can so that those muscles there, if they're compromised, that's going to make it harder to kind of hold on and not pee when you're trying to voluntarily hold it. So all right, so let's continue then. So actually now I can share this other one. So all of these things again are posted on your module. So you have access to all of these. And this is just kind of giving you a sense, kind of a prettier picture than I did of the kidneys and the urethra. And again, make sure you do know, like, again, a thing that could end up on your test is making sure that you know the difference between the ureters, which carry the urine from the kidneys to the bladder, versus the urethra, which is going from the bladder to the outside world. All right. Let's go. I have to stop this. So the kidney itself is what we're going to look at in more detail now. And the kidneys are where all of this balance stuff is happening. And I want to kind of try to give you a sense of this. So as we go deeper, you're kind of oriented into the different sections of the kidney. This, this renal pelvis, this is just where kind of the urine is actually gathering to leave. What we are going to be following is the blood coming in the renal artery, and it branches into smaller and smaller and smaller little arteries, into little arterioles, until we finally get into these little efferent arterioles. There's going to be like a million little efferent arterioles feeding into a million little tubule systems called nephrons. And they're all working in parallel. So we'll look at like one nephron to try to get a sense of what one nephron is doing, but you have to think about millions of these nephrons all working in parallel, doing all of this processing that we're talking about. The kidney has kind of two sections. This kind of outer section is called the cortex, which is just our more generic word for kind of the outer bark. And then there's this more intersection called the medulla. Again, this kind of means the marrow or the inner part. And we'll see the tubules of the kidney processing doing things in these different sections. The thing that you are going to need to keep track of is that the osmotic environment in the different sections of the kidneys is very different depending where you're looking. So if you are in the cortex, which is basically like this section, the osmolarity of the kind of interstitial zone is the same as you would expect in any part of the body, which is what would you expect kind of just your normal osmotic environment to be just amongst your body tissues?
High to low.
0.3.
Yeah, 0.3 osmolar. So when we are in the cortex, the zone, if you just look outside the cells are all just sitting inside and outside 0.3 balanced. When you get down into the medulla, due to processes that we're going to talk about in more detail from the juxtamedullary loops of Henle, you end up creating this really high osmotic gradient. By the time you get to the deepest parts of the medulla, it's like 1.2 osmolar. Oops. I'll just. And there's kind of this gradient, like it'll be like, if we're doing milliosmolar, it'll be 300 milliosmolar. If you're kind of here, as you go deeper into the medulla here, by the time we get down into this zone, we're going to be like around 1200 milliosmolar. That's going to be critical for concentrating the urine, right? If your kidneys are trying to keep water in your body, this osmotic gradient is going to allow the kidneys to just suck the water back into the body, right? Super salty means really high osmotic gradient to pull water back, right? That's why I keep saying osmosis is not going away, right? Osmosis is at the core of how these kidneys are going to do your water balance. By creating this really high osmolarity in the medulla of the kidneys, you have this really high gradient to pull water back into the body and keep it in the body if you would like. So we'll be seeing that in much more detail as we continue on. But that is kind of the picture here. And again, the renal artery is feeding into the kidneys, which then branches, again, in anatomy, you learned about the segmental arteries and the lobar arteries and interlobar arteries and the arcuate arteries and the cortical radiate arteries and blah, blah, blah. For this class, you don't need to know the names of all the branches. What you just need to know is finally that renal artery is going to feed like a million little afferent arterials that are feeding into these little nephron tubule systems, which I'm going to talk about right now. So, any questions about kind of this bigger picture of the bird's eye view of the kidney? Because what we're going to do now is get into the detail of these nephrons, these little tubule systems that are making up the kidney. Basically, like, you know, I think it's like a million nephrons per kidney, but it's just the same basic repeating pattern. So if you know one nephron, you basically know them all. All right, so let's talk about the nephron. So I can use my typing tool to make this go faster. Nephron. So this is basically the structural and functional unit of the kidney. And it's going to have three main processes, which we're going to talk about in more detail. We're going to talk about filtration. Filtration is where you are kind of taking the incoming blood and creating this stuff called filtrate, which we're going to talk about. It's kind of this indiscriminate, taking all of the fluid out from the blood and having it as this thing to work with. There's going to be tubular reabsorption. I'm not spelling that right. Where you're going to kind of make sure you hold on to the things you want to keep. I'll talk about this in much more detail in a few moments. And then the third part is going to be tubular secretion, making sure anything that you actually want to leave the body, you can actually put in this little kidney tubule, so it'll eventually leave the body in your urine. So we're going to look at this right now in much more detail. I'm going to start by talking about the, how do I get, I'm trying to get back to my drawing tool, but I can't find it. Nabbit. Right. Right. Hold on. We are having technical issues. All right, now I'm back. All right, so we are going to start by looking at these processes. Eventually, we're going to get more into the details of the nephron, the specific parts. There's different parts of the nephron, the proximal convoluted tubule and the distal convoluted tubule and the descending limb of the loop of Henle and the ascending limb of the loop of Henle and the collecting ducts and all this stuff. So we are going to look at all the different sections in more detail, but I want to start by looking kind of a big picture. What are the basic processes going on so you kind of understand those And then we'll go more into the detail about exactly how those processes are being carried out and what portions of the tubule are responsible. So kind of overview of nephron function. So the first step is the blood is coming in. This is my afferent arterial. Remember, this is kind of branching off from the original renal artery coming in. That's and again, if we're looking across all nephrons, we are talking about around 1.25 liters per minute of blood coming in as part of the inflow into all of the nephrons. This is then going to go into this specialized little balled up capillary called the glomerulus. These are basically little leaky capillaries. The exit from the glomerulus is actually another arteriole, an efferent arterial. So this is going to be another example of a portal system. Remember, we saw the hepatic portal system where you went into a capillaries in the digestive organs, then left and then went into a second capillary bed in the liver before finally going back. In this case, it's going to be two capillary beds as well. You start in the glomerulus, and then the efferent arterial is going to go into a second capillary bed, the peritubular capillaries, which we're going to talk about in a few moments. But let's start looking at the glomerulus. So in the glomerulus, they are very leaky capillaries. And you have the blood coming in actually under quite high pressure. This is kind of some of the highest pressure of any capillary beds in the body. So what happens if you have blood coming in under high pressure into really leaky capillaries?
Fluid goes out.
Fluid's going to go out. So this is the first step. This is what we call filtration. It's around 10% of inflowing blood becomes what we call filtrate. So this filtration, this is going to be, let me write this better, about 10%. So this is going to be water, obviously, and then small dissolved solutes. Big stuff like cells and large blood proteins don't get through, but small solutes. The thing about small solutes is that it includes both good stuff and bad stuff. Small solutes includes urea, which you want to get rid of, but it also includes, glucose and amino acids, which you're going to want to keep. So this is definitely not your urine yet. And in fact, let's think about this. If I have 1.25 liters of blood per minute going into all the nephrons, and 10% of that is turning into filtrate, how much filtrate am I making per day?
Just gallons and gallons.
Right, so we can figure this out, right? 1.25 liters per minute of blood times 0.1 liters of filtrate per minute. right? So we're going to have like 0.125 mils of filtrate per minute. And then if we multiply times 60 minutes per hour, and we multiply that times 24 hours per day, this ends up being about 180 liters of filtrate per day. Right, so this is obviously not your urine. If this actually was leaving your body, you'd be dead in minutes because you'd be losing all this water out of your blood. So the majority of the water, as well as all of the good stuff, this includes the glucose and amino acids and whatever. So all of the stuff that we actually want to keep in our body, like the majority, like 99% of that water, and all of the small solutes that are actually nutrients that we want to keep, we need to reabsorb, bring them back into the bloodstream. So let's look how that happens. So what we're going to do is we're going to capture this filtrate in this renal tubule. That's not what I meant to do. There's this thing called the Bowman's capsule, or renal. It's kind of like a catcher's mitt holding on to this glomerulus, this little balled up thing of leaky capillaries, and it captures the filtrate. So now the filtrate is going through here, and this is going to give us a chance to process it. So now we're going to take that afferent arterial, and we're going to see where it goes. The afferent arterial is going to become now the peritubular capillaries.
What was the thing that you drew in green that surrounds it?
So the renal tubule. So when we talk about the nephron is like the glomerulus and is associated with this renal tubule, which is, and all the peritubular capillaries that we're going to talk about now. Right, so we had blood coming in, filtrate formation in the glomerulus, efferent arterial, feeding into another capillary bed, this peritubular capillary bed. This is now going to head back to the veins. But in this process now in the tubule, we're going to have to do some major reabsorption. So stuff that is in the filtrate that we want to keep in the body, we're going to do this thing called, this is going to be part 2, tubular reabsorption. This is going to be like 99% of the water and all of the nutrients and the things that got kind of filtered into the filtrate that you want to hold on to. So tubular reabsorption is pull back into the body the stuff you want to hold on to. The other thing, though, if there is stuff in your body that you want to get rid of, then you can take it from inside the bloodstream and actively move it out of the capillaries into the tubule, and it will eventually leave the body, as your urine. The stuff at the end of this all is going to be urine. So this third thing, which I mentioned a little bit ago, is tubular secretion. Take stuff that is actually in the body and move it out of the body into the tubule so it can be excreted. Ends up in your pee. Tubular reabsorption is, again, taking stuff that is in this filtrate that you actually need to hold on to. Right, when we saw the glucose in the urine, when we did, hopefully nobody saw it, but when we talked about why there's glucose in the urine for diabetes, it's because there's so much glucose in the blood. That means there's so much glucose in the filtrate, and it overwhelms the kidney's ability to reabsorb all the glucose before you make it to the end and make the urine. So there's still some glucose left by the time it turns into urine. Right. So hopefully it's kind of making sense, kind of coming together when you think about it that way. So any questions about this? All right, so
Sorry, I have a quick question. So the efferent arterial that's like the same thing as the peritubular capillaries. It feeds into them. Not the same thing, but it feeds into it.
right, so this is going to be what we call a portal system.
Okay.
Where this afferent arterial feeds into capillary bed number 1 and then feeds into capillary bed number 2 before ultimately returning back to general circulation. All right, so what we're gonna do now, there's a couple
Quick
of things.
question.
Oh, yeah,
Sorry about that. For step 2, like let's say glucose is going back in, is going to be reabsorbed by the bloodstream. That's all going to be active transport, right?
it's
Or at
gonna
least for
be
glucose.
exactly the same as we saw when we talked about absorbing glucose from the intestine. So that transepithelial transport using the glucose sodium symports and glucose carriers and primary and secondary active transport. It's going to be all that, the same story. That same story we saw for, actively pulling glucose in from the intestine into the capillaries. You can have the same basic mechanism here. Right. This is why it's rate limited. And I talked about, because it involves carriers as part of transepithelial transport, and transepithelial and carriers are limited in the total rate that you can move things across the membrane. So that's why people with diabetes have so much glucose that you've maxed out the maximum facilitated diffusion rate across those carriers that are part of that transepithelial transport.
Okay, thanks.
Right, and we'll see as we go through the nitty gritty, some aspects of the reabsorption are passive, particularly as the tubule gets down into the really salty parts of the medulla. All you need to do is open up a water pore and water is going to suck back into the body via osmosis. But then there are going to be other parts of the system where the reabsorption is active, where you have to use energy to pump things. So some of the reabsorption will be passive, like due to osmosis. Some of it will be active due to different kinds of transport. Okay, so let's see, what we're going to do now, we're going to focus on the actual filtrate formation. Maybe so this filtration, obviously for the kidneys to be working properly, you need to have filtrate formation. And it's worth talking about how filtrate formation is controlled. And then it's going to make sense why the kidneys care so much about blood pressure, right? Because blood pressure is ultimately what is making the filtrate happen. If you don't have enough blood pressure in this afferent arterial, you're not going to have this filtrate forming. You're not going to have the fluid leaking out to start this whole process. In fact, if your blood pressure is too low, you are going to go into renal failure because your kidneys aren't making the filtrate. So that's why the kidneys release renin. If the kidneys notice blood pressure dropping, they care a lot about making sure the blood pressure stays up, because the filtrate is not going to form if the blood pressure isn't adequate. Okie dokie. Let's talk about filtrate formation. So what kind of capillaries probably make up the glomerulus? What kind of capillaries were the super leaky capillaries?
Fenestrated?
Exactly. So these are going to be fenestrated capillaries. And so part of what determines what can leave the blood or what stays in just has to do with the nature of the capillaries themselves and the size of the little pores. But then it turns out that the cells of the tubule that kind of grab on also help determine what comes in or out. So I'm going to put the renal tubule here now. Again, this whole thing here, you often call the Bowman's capsule. The cells of the tubule actually kind of grab around the capillaries, and they have like little slits. They have little finger-like extensions that, in fact, this is something probably is just going to be faster to show you as a picture rather than me try to draw it pretty. This is, yeah, so this is again, reiterating afferent arterial, Bowman's capsule where filtration, the F is happening, reabsorption, the R back into peritubular capillaries, secretion, moving things out of the body. This is showing the cells, these podocytes. These podocytes are the cells of the tubule that wrap around the capillaries. And they have these little things, they're called filtration slits or slit pores, where the little fingers kind of interleave. So these filtration slits. So together, a combination of the properties of the fenestrated capillaries, along with these little slits made by the podocytes of the cells that go around, that's what's making the filtration membrane that determines what stays in the blood and what can leave. So there's this kind of filtration membrane. So the stuff that can move through is really small stuff, like water. Water comes out. Really small things like, again, like I said, small solutes, glucose, urea, amino acids. I have like some actual size. I think it's things. I think it's around things like greater than 3 nanometers go through easy, and things that are bigger. Don't let me. Where's my little actual number? Here it is. Yeah, so things smaller than 3 nanometers can go through easy. I should say small, how to do it. So things that are bigger than like around 9 nanometers are blocked completely. So that means things that are blocked, things that can't get out are things like cells and plasma proteins. So the things that are blocked include like, the cells, kind of the large, the large proteins. Right, that's why when you're looking in that urinalysis for protein, if you are seeing a lot of protein in your urine, that means there is some compromising of this filtration membrane. Something is breaking it down, or the blood pressure is so high that it's pushing things through that shouldn't be getting out. So that's, normally you should not see these large proteins in your urine because they're blocked by this filtration membrane. And again, like I said, that's part of why you're looking for that in the urinalysis, because it's giving you evidence that something is wrong with the functioning of this filtration membrane. So now what we're going to talk about is the actual kind of formation of the filtrate, which is going to be driven by what we call the net filtration pressure. So let's first talk about the rate here. Rate is going to be GFR, glomerular filtration rate. So I have already kind of mentioned what it is. We said that this glomerular filtration rate normally is going to be about 10% of the blood inflow. Since the blood inflow is going to be, I said 1 to 1.25 meters, the glomerular filtration rate is typically about 100 to 125 mils per minute. This is typical. Later on, when we're looking at the more details, I'm going to stick with the 100 because the math gets so much easier. But somewhere between 100 to 125 mils per minute of filtrate forming. The glomerular filtration rate can be assessed in a number of different ways. One way is when you look, another thing people look at in urinalysis is levels of creatine, or creatinine, I should say, which is a byproduct of muscle metabolism that tends to get produced at a fairly predictable rate. So you can look at how much is showing up in the urine, and that gives you a sense of what is the approximate rate of glomerular filtration. If you want to get even more fancy and get a readout on glomerular filtration rate in a clinical setting, you can give people inulin. Inulin, which is a sugar. And it is not reabsorbed or secreted. So if you give somebody a known amount of inulin, you know it's in their blood, then you know that it's just showing up in the tubule at whatever rate that the filtration rate is happening. And since it is not being reabsorbed or secreted, it's going to show up in your urine at whatever rate that the filtration is happening. And so it's kind of a non-invasive way that you can actually get a measure of somebody's glomerular filtration rate in a pretty accurate way. Again, what is ultimately controlling glomerular filtration rate? What's driving the movement of the water and solutes out of the capillary into the tubule?
Blood pressure?
Yeah, the blood pressure. So ultimately, this is all going to be driven by what we call the NFP, the net filtration pressure. Right, so it's going to be worth spending a few moments talking about what exactly creates this net filtration pressure, this pressure, it's ultimate pressure that's moving things out of the glomerulus into the tubule for processing. So let's do with that. Maybe I'll erase this other stuff here. Give myself some more room. So let's talk about the things that create this net filtration pressure. Obviously, it's going to be driven just by the blood pressure coming into the glomerulus to start with. So that is just called the glomerular hydrostatic pressure. It's just basically the pressure coming into the glomerulus from this afferent arterial. And like I said, it's higher than into most capillary beds. It's typically about plus 55 millimeters of mercury. And we talked about in normal capillary beds, it's typically more like 40 or something. So that's the pressure pushing in, but there are going to be pressures pushing back. There's going to be a couple of pressures pushing back. In fact, we've talked about one of them when we talked about normal capillary beds. As water leaves the blood, what's going to start happening? What was happening at the far end of just your continuous capillary beds?
The osmolarity goes up.
Exactly. The osmolarity inside goes up, which means there's going to be an osmotic pressure pulling stuff back into the blood. So we're going to have an osmotic pressure. So that's going to be fighting us. And that's going to be about, I have here 30 millimeters of mercury. And then the other back pressure is just going to be, if you try shoving a bunch of water into this kind of limited space, you're just going to build up back pressure pushing back. So just what we call the capsular pressure. Capsular hydrostatic pressure. Heck.
I'm sorry, can you repeat what that last one is?
I will. So basically, as you keep pushing water into this kind of limited space, you start building up a back pressure in here that's pushing back, right? So if you keep trying to push water across the membrane into this kind of closed off area, you'll start getting back pressure pushing back at you. So that's what this is. This is going to be like around 10 millimeters of mercury. So if you put it all together, it ends up being a net filtration pressure of about 10 millimeters of mercury. So you can see that you really need to control this glomerular hydrostatic pressure to make sure you have this adequate net filtration pressure to drive the glomerular filtration rate. This is why the kidneys are so concerned about your blood pressure. We'll talk in more detail about the different ways that you can do this. What's one way the kidneys can help make sure that there is adequate net filtration pressure?
Renin angiotensin.
Exactly. If we're going to see this juxtaglomerular apparatus, notices the blood pressure dropping, it's going to trigger the renin angiotensin mechanism, which will bring the pressure back up. to maintain our net filtration pressure and maintain the glomerular filtration. There's also a lot of control of these afferent and efferent arterioles. If you're trying to increase pressure in the glomerulus, you can dilate this and constrict the outflow to build up more pressure in there. If you have too much filtration pressure, you can constrict this a little more. But so there's a lot of control of the afferent and efferent arterioles also to help adjust this pressure to make sure that you are having adequate filtration. What do I have here? Yeah, I don't have the actual pressure where your kidneys shut down, but obviously, like I said, not having adequate blood pressure is going to affect your kidney function, because without adequate hydrostatic pressure in the glomerulus, which is what's driving this whole thing, you're not going to be able to have adequate filtration pressure to create the filtrate. Without the filtrate, nothing else is happening. So any questions about that? All right, nice. So let's
Quick question, sorry. So that net filtration pressure of 10 milliliters of mercury, if that is normal-ish and that is like at that pressure, that's going to be adequate to have your 0.1 liters going through the I cannot say that word, glomerulus. Glomerulus, I don't know.
Yeah.
So that's enough pressure. That's all normal
in fact,
numbers.
that's normal number. So
Thanks.
glomerulus. It comes from like glomus, which is a ball. Continue here. So I just want to add a little bit more about the other parts of the kidney tubule. So we have that as a base. Whoop, not that one. Okay. So nephron. Kind of more detail. So we talked about afferent arterial going into the glomerulus, efferent arterial, then the tubule starting. You know, so far all I have showed you with the tubule is a kind of straight shot with absorption, reabsorption, and secretion. But in reality, it has a section where it's really twisted up, called the PCT, the proximal convoluted tubule. Then it has this section where it goes down into the descending and ascending limbs of the loop of Henle. It was a different anatomy. This was not originally described by the dude from the Eagles. Then there is another twisted up place called the distal convoluted tubule. The DCT then actually makes a little detour and it touches the arterioles at the glomerulus. So I'm gonna do my best to show it going here. So this little section here, that's a mix of the DCT as well as the afferent and efferent arterials. That is going to be the special thing that's monitoring blood pressure and filtrate composition, and that's going to release renin if necessary. So this part here, which we'll talk about next class, this is what we call the juxtaglomerular apparatus. So, we talked about the kidney monitoring blood pressure and releasing renin if blood pressure is dropping. It's actually cells in this juxtaglomerular apparatus that are actually doing the monitoring and the releasing. So again, we'll talk about it later, but just for laying out the anatomy, I want to make sure you have a sense of what the heck the JGA is. That's another, if you have trouble saying just glomerulus, probably saying juxtaglomerular apparatus will be even like more challenging, but all right. And then finally, the last part of this whole system is going to be what's called the collecting duct. There are more than one collecting or more than one nephrons that go into a common collecting duct. And when you're at the end of the collecting duct, this just goes out. This goes into what's called the renal pelvis, which is the collecting zone for the stuff that's going to go into the ureter. So once we're out of the collecting duct, it's urine. This is now urine here. Other things to make this picture make a little more sense. I'm going to draw a kind of demarcation line between the cortex, which was like 300 milliosmolar outside, and the medulla. So when we get down in here, it's like 1200 milliosmolar. So you can see this means if you're down, like if you're in the collecting duct or in the loop of Henle and you open up a water channel, you're going to be sucking water back into the body, right? This really high osmotic level creates this gradient that's going to be necessary to pull the water back into our body. So that makes sense? Like when we talked about ADH, telling the kidneys to reclaim more water, it's about, ADH is going to open up aquaporins in the collecting duct. And if you open up aquaporins, water channels, that's going to mean more water is going to leave the filtrate and go back into your body and not end up being the urine, right? That should feel kind of intuitive. If I open up an aquaporin, a water channel in this tubule here, there's going to be this huge osmotic gradient to suck water back into the body, right? Does that make sense? We're not going to go into the detail of it. I'm going to give you a little, what is it? For further study, I'll give you a YouTube link where you can look more in detail at how this loop of Henle actually helps create and maintain that osmotic gradient. It's actually very cool, but given the time, it's not going to make sense for us to like go into detail in class. But this loop of Henle ultimately, in addition to doing other things that we'll see, is going to be responsible for creating and maintaining this osmotic gradient. In fact, what do people know what Lasix is? A lot of people get prescribed Lasix as a drug for like blood pressure. No. So it's it's one of the really common diuretics, like drugs you would take as a diuretic, and it's in a class called a loop diuretic. You know, and the way it works, we'll talk a little more detail about it later, but it works by affecting the loop of Henle and making you actually have less of an osmotic gradient, which means you're not going to be pulling back as much water into your body, which means there's going to be more pee getting formed. Right? So we'll talk about this in more detail, but like loop diuretics work by having less of an osmotic gradient, which means you're not going to be as efficient at sucking the water back into your body, and more of it is going to end up just leaving as urine. You'll pee more. So hopefully that kind of makes sense. Look at it. Okay. Let me I should mention, just for completeness as well here, right? Obviously, the peritubular capillaries are down in here as well, because that's how we do the reabsorption and secretion. So when we are in the PCT is where a lion's share of the reabsorption happens. So we are taking stuff that is in the tubule, whether it is sugar or water or whatever, and we're pulling it back into the bloodstream. Right? This is where we have the majority of the reabsorption happening. So like, what do I have here? Reabsorbs 65% of the filtrate. You know, the PCT is where you're reabsorbing a bunch of water. You're also reabsorbing, like I said, nutrients, sugars, and amino acids and things like that. Let me see, I'm looking at so yeah, I think we do. I'm going to go and do a little monitoring of what the osmolarity and what the volume of the filtrate looks like at various points along this path. I think that will
before
be
you leave.
Uh-huh.
Sorry, before you leave this, is that blue dotted line separating the cortex from the medulla of the kidney?
Exactly.
Roughly. Okay, thank you.
Yeah, exactly. And I should say, not all nephrons have the loops of Henle that go so deep like this. They're specialized, called juxtamedullary nephrons, but don't worry about it for this class. So if we look at osmolarity of the filtrate and we look at the amount of filtrate, I think that will be a useful way to kind of just see how this processing happens. You know, when we start at the very beginning, there's going to be about 100 to 125 mils per minute of filtrate. For the purposes of our discussion here, let's just say 100, because the math is going to be so much easier. So when we get started here, it's about 100 mils per minute is the amount that's coming along, that's being formed. You know, and we're letting go of both water and solute, so we end up having kind of the same osmolarity as the blood. It's going to be about 300 milliosmolar. So when we first look at the filtrate as it comes into existence, we're making about 100 mils per minute across both kidneys, all nephrons. And the osmolarity is about the same as normal body fluids. By the time we're done with the PCT, we've reabsorbed 65% of the volume. So now we're only at like 35 mils per minute. Right, we've already reabsorbed a lot of the water. We still got to reabsorb more, but we've already reabsorbed a lot of it. So now there's much less fluid passing by. And we've been reabsorbing solutes as well, not just water, but solutes. So the osmolarity is still going to be 300 milliosmolar. So by the end of the PCT, we have reabsorbed about 65% of the volume and a bunch of solutes, and the osmolarity is still about the same. I should say, for completeness, the PCT, while it's primarily a place of reabsorption, it also does some secretion as well. So reabsorption and some secretion. The loop of Henle is where things get kind of complicated. So the descending limb of the loop of Henle, permeable to water. So it has these aquaporins. What is going to happen if you have this filtrate, which is currently at 300 milliosmolar, and all of a sudden it's going down into this zone where it's 1200 milliosmolar outside and permeable to water. Water can move.
The water's going to move out.
Yeah, water's going to totally leave the tubule and go back into the body, right? But that's why I keep trying to say, think osmosis, you want it to be intuitive. If it's really salty outside compared to inside, there's a high osmotic gradient and the water is going to move towards where it's super salty. So the water, water leaves, which means by the time we get to the bottom here, what's the volume going to be like?
Really minimal.
And we're going to reabsorb a bunch. We're going to reabsorb another 20% of the original like volume. We're going to be down to maybe 15 mils mils per minute. Right? Because we've just reabsorbed a bunch more water. So there's a lot. Now we're down to only like, a tiny fraction of the original volume of the filtrate that got started. What about the osmolarity of the filtrate when we get down here to the tip of the loop of Henle?
Goes up.
It's going to go way up, right? If you're losing a bunch of water, I should say permeable to H2O, not solutes. So the solutes are staying in the filtrate, but the water is going out, which means it's just getting more and more and more concentrated. In fact, water is going to keep moving out of the tubule into the back into the body until the osmolarity of the filtrate is what? When will the osmosis stop?
1200.
1200, exactly. When it's so much water has left is that there's no more osmotic gradient. So it's going to be 1200 milliosmolar. Super salty. Right? Does that make sense? The ascending limb of the loop of Henle is going to have very different properties. It's actually going to be pumping sodium out of the tubule. So ascending limb of the loop of Henle actively pumps sodium out of tubule. So brings it back into the body. But it's impermeable to water. This is getting messy.
So the first part, only water can move, and then the second part of the loop, only solute can move?
You have it exactly correct. So this first part, let me get back here. The first part, only water can move, but not solutes. The second part, impermeable to water. But actively pumps out sodium out of the tubule. So the water stays behind now as we keep pumping sodium out. And as we keep pumping sodium out, I mean, basically the power of this pump, it's strong enough to maintain a difference between the inside and outside of up to about 200 milliosmolar. If the difference across the membrane gets higher than 200, it doesn't have enough power to keep pushing more out. But by the time we get up to the top here, as we enter into the DCT, we are going to actually be quite a bit lower. So we're in the DCT here now. We are going to be down to about 100 milliosmolar. It's bad looking 100. Right, we have been pumping out so much salt as we're going back up. The water that's left over is very diluted. Again, because the water didn't leave. The volume is still going to be the same. We're still, but it was 15 mils per minute here. It's still going to be 15 mils per minute because we didn't change the amount of water. But we got rid of a lot of the salt. So now it's very dilute. The DCT is going to do just more, it's mainly secretion and some reabsorption. So more processing in the DCT. And then as we enter into the collecting duct here, it's still going to be about this. So this, if we don't do any more major processing of this before it becomes urine as we come out of the body, we're going to have very high amounts of very diluted urine because there's still quite a bit of volume here and it's very diluted compared to your normal body fluids. What if I'm dehydrated and I want to keep more water in my body? What am I going to have to do?
Reabsorb it.
Reabsorb it. And I can reabsorb it by putting these little aquaporins in this collecting duct. You know, from its name, you can tell aquaporin. It's a pore for aqua, for water. So if we insert aquaporins here in the collecting duct, and we have this 100 milliosmolar filtrate coming through, and it's 1200 milliosmolar on the outside, what's going to happen? Osmometer lab, huge freaking gradient.
Wow.
Say it again.
saying it's 1200 on the outside and and the osmolarity is lower in the collecting duct, correct?
Correct. It's only
So it's
100 in the
gonna-
collecting duct, and it's
The
on.
water is going to move out of the collecting duct into towards the higher osmolarity.
Right. The water is going to go back into the body because of the osmotic gradient. We have this huge concentration gradient of solute across the membrane. So the water is going to get sucked back into where it's super salty on the outside of the tubule, back in the body where there's the capillaries that are there to kind of pick it up and take it away.
So that's the biggest gradient of the whole system so far, right? That we've seen.
I mean, it's 1200 down here and it's, yeah, no, you're right. That's, yeah, so that is the kind of the biggest gradient. This is the main place where you adjust the amount of water or not in your urine. By having more or less aquaporins, you either are gonna, if you're trying to conserve water, you'll insert a bunch, which is gonna pull back lots of the water, and you'll have very little. You might only end up having like maybe, 1 mil per minute coming out. You might have reclaimed, 99% of all of the volume. Whereas if you don't use the aquaporins, you'll have a much larger volume coming out if you're trying to actually let go of water because you've been drinking a bunch of water.
So are the aquaporins, I'm sorry, it's like they open and close, or?
They more get, I don't know if you remember back in the day, I talked about endo and exocytosis can be used to insert things in the membrane. So rather than actually having it be gated in the way you're thinking, you can either take this little vesicle full of channels and store it in here, in which case it's effectively no aquaporins, or you can do exocytosis and fuse it with the membrane, and now effectively those channels are inside the membrane. And if you now want to get rid of them, you just have to pinch this off and now you're back to this state. So you can very quickly change the permeability of the membrane by either endo or exocytosing that little vesicle. What controls the aquaporins?
ADH.
Exactly. Aquaporins. ADH. So ADH equals antidiuretic hormone, also known as vasopressin. Vasopressin because it is also a vasoconstrictor and increases blood pressure, right? Those are synonyms. So ADH, you've met already. It's released by the pituitary. We'll meet again actually in a couple of weeks. But ADH works by inserting aquaporins into the collecting duct. When you insert the aquaporins, that means that more of the water is getting sucked back into the body, which means you pee less, antidiuretic, don't pee as much. So that makes sense? What happens, like when you drink alcohol, alcohol will inhibit the release of ADH. How will that affect things?
It'll dehydrate you
And why? How?
because you're peeing more.
Yeah, exactly. So it's basically you're going to pee more. So if you're drinking alcohol, if that means your body is not sending the message that it would have to insert the aquaporins, which means more of your fluid is leaving your body that normally would have been retained, which means you're going to pee more, which most people have probably experienced, and you can also get dehydrated, which probably most people have experienced. Yeah.
Are there also aquaporins? I mean, you said that the descending loop of Henle is also permeable to
Yeah,
water.
so that they also have aquaporins. So that's where the water is, how the water is getting out. But there you don't gate it, or you don't, it's just always sucking the water back there.
So that is not really affected by ADH. The ADH
The
is
ADH
all in the
affects
collecting
collecting.
duct.
Yeah. But, and then, yeah, so that's the last thing I will put in here just for the collecting duct. Another hormone that works there that you have seen already. So just for kind of completeness, what was the other hormone I said works in the kidneys as a result of the renin-angiotensin mechanism?
Aldosterone.
Yeah, aldosterone. Aldosterone, again, which we'll meet again in the endocrine system, but it turns on sodium pumps in the collecting duct. So if your body is trying to conserve sodium, this picture has gotten really ugly. Let me get rid of some of the stuff here. That's not what I meant to do. If aldosterone, then you turn on these sodium pumps and reclaim more sodium into the body. So aquaporins are controlled by ADH. Aldosterone controls the sodium reclamation. They can be independent, right? If your body is trying to reclaim sodium, it can put on the aldosterone and turn on those sodium pumps in it. But if you want to maximize your conservation of water, you do both, right? Because if I want to maximize how much water I'm pulling back due to using osmosis, I'm going to maximize my gradient. So I'm going to pull even more sodium out of the tubule, which means water is going to follow, right? So that's why we saw both aldosterone and ADH being released together by the renin-angiotensin mechanism to maximize kind of water reabsorption. But they can be controlled separately as well. You can insert, or you can do the aquaporins independently. You can do the sodium pumps independently using the different hormones. But often they're together in order to maximize water reabsorption. That makes sense? So let's leave that there. On next week, we'll kind of tie this up with a few last points and also talk more about the juxtaglomerular apparatus. But this is the basic story. And I can show you a picture that will be useful. When you're thinking about, I drew kind of a weird squiggle of the peritubular capillary, but your book has prettier pictures that I think are worth looking at. Where is it? So this is kind of showing this in a prettier way. Glomerulus, PCT, loop of Henle, DCT. I want even a better picture. Oh, here. This shows you even a nicer or a more realistic picture of how kind of messy it looks, where you have the glomerulus here feeding into the PCT, into the loop of Henle, into the DCT touching the original arterioles feeding in and then feeding into the collecting duct, and meanwhile, all the peritubular capillaries running around everything. So just kind of giving you a sense, that's kind of what it looks like in more big messed up or big mixed up look. And again, like a million of these things per kidney. Your book will probably talk, yeah, don't worry. The vasa recta are the specialized capillaries down in these deep loops of Henle that help maintain the gradients and things, but don't worry about the details for our class. So any questions about this as we've covered so far?
Can you go back to the main drawing you've been working off of? What, and just, I think I saw it, but what was the flow at the end of everything? At the end of, by the time it's lower in the collecting duct? The
It
flow and
depends.
osmolarity?
So that would be right here.
Yeah.
And that could be anywhere from like 15 mils per minute if you don't reabsorb any of the water, or it could be down less than 1 mil per minute if you're maximally reabsorbing water. So the flow and the concentration at the very end, at the end of the collecting duct, is going to depend on the body's needs and on what these little hormones are present or not and all that.
But the concentration would come up a lot from 100 milliosmoles where it's starting. Right?
Absolutely. Yeah, no, it can be like super, super concentrated. In fact, we'll see that in the lab next week. People who are dehydrated have really high concentrations of sodium and really high specific gravities, meaning lots of dissolved stuff in their urine.
Okay.
So, but yeah, so, if we think about at the end of the other sections, it's more predictable, but by the end of the collecting duct, it's completely unpredictable because it depends on what activity is going on in the collecting duct based on the body's needs. So